Well, welcome to Ellevate Louisiana's December Cancer Advocacy Policy Committee meeting. I'm Julie Stokes, founder and CEO of Ellevate. Today, we're joined by Dr. Xiao-Cheng Wu and Dr. Donna Williams to discuss the Louisiana Tumor Registry and public health trends for cancer in our state. Dr. Wu is the director of the Louisiana Tumor Registry and a professor of epidemiology at LSU Health Science Center. With more than 25 years of experience, she leads Louisiana's participation in the NCI SEER and CDC NPCR programs. She has authored over 200 peer-reviewed papers and serves as a principal investigator on major national studies focused on cancer screening, care quality, health disparities, and using registry data to improve cancer outcomes statewide. Dr. Williams has more than 30 years of experience in public health. She directs the Louisiana Cancer Prevention and Control Program, leading statewide efforts to reduce cancer disparities and expand prevention and early detection, especially for underserved communities. A long-time CDC-funded program leader and educator, she focuses on removing barriers to screening and translating research into practical community-level impact. Dr. Williams also serves as the Associate Dean for Public Health Practice and Community Engagement at the LSU School of Public Health. Dr. Wu and Dr. Williams, thank you for joining us. We're excited to hear from you both. So in order to waste no time, I will go ahead and turn it over to Dr. Wu, who's going to give us an overview of the Louisiana Tumor Registry.
Great. Thank you so much, Julia, for the introduction. Good afternoon, everyone. Thank you so much for inviting me to speak today. So I'm really honored to have this opportunity. So,
we are too.
Yeah.
Thank you.
So the title for my presentation is Evidence-Based Strategies for Cancer Control Through Data. So let me say that. This is the outline of my presentation. I hope I can finish this. And if not, I just cut short. So the first, I'm going to talk about a little bit about Louisiana Tumor Registry, the role of LTR data and data sources, and talk about cancer burden and risk, early detection, policy opportunities, LTR. LTR stands for Louisiana Tumor Registry priorities, and environmental patterns. And hopefully I have time to just talk about the data visualization tools. And at end, if we have time, we'll have a Q&A section. So Louisiana Tumor Registry, I don't know whether you all know about Louisiana. You probably heard, but this is a definition Louisiana Tumor Registry I have. Louisiana Tumor Registry is legally authorized to undertake the ongoing and systematic collection, storage, and management of essential population-based cancer data. It serves as a vital resource for cancer surveillance, control, and research. So you see, I highlight few words because first, our data, we have to have an authority, right? Because our data source from medical record, if we don't have an authority, we cannot access identifiable data. And our data collection is ongoing. We have collect statewide data since 1980s. Our data collection also systematic. That means we actually use a national standard to collect the cancer data. Our data is population-based. Population-based, so we can use the Louisiana Tumor Registry data to calculate cancer incidence rates and identify areas with a higher cancer risk and also monitor cancer trend. Really, LTR data serves as a vital resource for cancer surveillance, control, and research. So this is the Louisiana Tumor Registry mission. We emphasize complete, high quality, and timely data. This is very important because if our data incomplete, Then you just say, oh, we want to say whether that geographic area has high incidence rate, but because underreported, then we cannot, the rate will be underestimated. High quality and timely. We see even our data very good, but 5 years behind, that's still just not good. So our focus is to collect, report, complete high quality and timely population-based data. Our vision is to reduce suffering and death from cancer using data we collected. So I think this committee, we share same vision. And the Cancer Control Program, Dr. William lead, we also share the same vision. We want to reduce suffering and death from cancer and in Louisiana. And I want to just quickly talk about cancer control continuum, because cancer control not just prevention. It's just from prevention, early detection, diagnosis, treatment, and survivorship. Louisiana tumor registry data has been used for all this. For example, prevention, we call primary prevention. Our data can identify high-risk areas and populations. Our data can monitor cancer incidence trend, right? So this information can be used, inform target prevention programs. Even we say we try to reduce exposure to risk factors of cancer, some people will eventually diagnose with cancer, but we want to detect cancer or diagnose cancer as early as possible. Then you just say how LTR can help, because our data can identify target populations for early detection. Because Cancer Control Program, we say in Louisiana, this area, they have a high proportion later stage cancer diagnosis, for example, colorectal cancer. Then the May Cancer Control Program can implement some interventions to improve early detection, right? Our data can evaluate cancer screen effectiveness, because we say before intervention, after intervention, we say whether shift the cancer diagnosis from later disease to the early disease, right? Assess access disparities. A diagnosis is very important, because a national guideline, they have just a recommended workup. This is important. Our data, for example, we say colon cancer. Colon cancer, they just say you need to remove 12 lymph nodes, because if you remove less than 12 lymph nodes, you may miss positive lymph nodes. Because stage 3 colon cancer, chemotherapy can reduce the death rate up to 30%. But you think about if you just remove 2 lymph nodes, then you miss that the positive lymph nodes, then your treatment completely different, right? No chemotherapy, then patient just say, later you find cancer metastasis to other side. So this diagnosis is very important. Treatment, we conduct many studies to assess cancer care, quality cancer care. For example, breast cancer, we say that national, they say the NIH consensus statement say breast conserving therapy, that's recommended because it's a equivalent survival compared with mastectomy. Mastectomy just remove breast and also muscle. But that was early 1990 NIH consensus. Recent studies, even our own study, use Louisiana tumor registry data. We find women receive breast conserving surgery, they have a better survival. We also find the trend, actually, women receive mastectomy increase. We see why that's the case, because we have data. We published one paper, we found travel distance to radiation facility is an important factor. Because if women receive breast conserving surgery, they need to have the post-surgery radiation therapy, like for 4 to 6 weeks, almost every day. Then travel, that's the problem. We found especially among those age 65 years and older, right? And the survivorship care. So the tumor registry data can be used for all this. We closely collaborate with Dr. Williams' team and use our data to guide the cancer control plan program. You see where you get the data. So this is a data sources, Louisiana tumor registry. We collect data from pathology lab, in-state, all-state pathology labs. because we know over 95% of cancer cases diagnosed with a microscopic confirmation, means get a pathology review, right? So if we capture all pathology reports, real time, now we do electronic pathology reporting, we capture majority of the cases. We also collect data from hospital. In Louisiana, we have over 130 some of the hospitals diagnose and treat cancer patients. Then the COC stands for Commission on Cancer. This is a program sponsored by the American College of Surgeons. So hospital, if a COC facility, they required to have the cancer registry. So because they use the cancer registry data to evaluate patient care. So in Louisiana, over 130 some of the hospitals, then 20 some with COC program. So they can submit data to us. But all other healthcare facilities, we have to collect data. We collect data from like freestanding surgical center, radiation center, other treatment center, and even like oncologist office, urology, dermatology. Say, many years ago in 1980s, we primarily collect data from hospitals. But now we know the cancer care shift from non-hospital settings. Many patients receive surgery at freestanding surgical center and receive maybe chemotherapy at oncology offices. So we have to get the data from all of them. And we also link our data with death certificates every year. If a cancer lists as one of the cause of death, not in our database, we have to investigate. We link our data with the National Death Index because some of the Louisiana residents diagnosed with cancer, and then after diagnosis cancer move to other state. Then we want to, because we follow up a patient, so we can calculate the survival. We link with Social Security administration, Social Security Death Index, the Centers of Medicaid, Medicare Services. We get follow-up information. Nursing home, hospice, and we also have an interstate exchange program. Why? Because some Louisiana residents may be diagnosed or treated other state. For example, MD Anderson. Many Louisiana cancer patients, they just went to MD Anderson, get consultation or receive treatment or confirm treatment. So and also pediatric cancer patients just receive care at St. Jude Children's Hospital. So we do data exchange. We establish data exchange agreement. So we do exchange with 45 states, DC, 3 US territories, even Bermuda cancer registries. We just, because when we calculate incidence rate, denominator, Louisiana population, but numerator, newly diagnosed cases. You think about if we miss some of the cases diagnosed in other state, then cancer incidence rate will be underestimated, right? So we also, every year, we link our data with statewide hospital inpatient discharge data, because the discharge data, they have a diagnosis code. If cancer mentioned, not in our database, we have to investigate. So this is, we do all this just to ensure we have complete high quality data. And okay, I want to give you some because I just say 20 minutes, I cannot give you show you all the cancer data. So I create this table. There's a cancer incidence rate in Louisiana and the US. So this column is Louisiana, this column US. This is Louisiana incidence rate versus US. And this is for the diagnosis year 2017 to 2021, because I want to get a rank from state cancer profile. Actually, Louisiana Tumor Registry website, we already published data up to 2022. So this is a major cancer site. I cannot list all cancer sites. Yeah. So this is just for this time period. But if you look at different time period, the pattern may not be different. Basically, you can say Louisiana, almost all these cancers, the Louisiana rate succeed US rate, right? Succeed, like all cancer about 9% higher, and prostate cancer 25%. Look at the kidney cancer, 35% higher, liver cancer 23%, so all higher. Here, this is a rank, means nationwide where Louisiana stand. So for all cancer, our incidence rate rank number 4, and prostate cancer we number 2, kidney cancer number 1, and like liver bile duct, this is number 3. Then you just say, what's this? This is just a trend, but this trend, not long-term trend, looks like the state cancer profile, they look at 2017, 2021. So if a yellow arrow, this is a leveled, but the red color, red arrow, this trend increased. Only lung cancer, we see decline. And all cancer combined, colorectal cancer level, cervical cancer level, but all other increase. So that's our problem. Even we say, oh yeah, we see we see lung cancer decline, but if you look at tumor registry data visualization tool, Louisiana rate still higher than the national average. So this incidence rate, you say this is an age-adjusted incidence rate per 100,000. That per 100 population, this is a number of cancer cases. So, but for breast cancer, even actually I look at 2022, we see rate decline a little bit, but for this time period increase. Breast cancer, the rate about the same. You say the Louisiana and the US. So this gave you some picture because of course this not break down by the age group, by the race, ethnicity, but just all urban, rural. This just gave you overall picture. Basically just say Louisiana cancer rate succeed US for most major type. And even some we say decline or leveled, but Louisiana rate also higher than national average. So that's where we stand. And how about mortality rate? Mortality rate actually you say better because see the green arrow, this decline. Even we say decline, this prostate leveled and pancreatic cancer level, liver cancer leveled. But even we say decline, you see the most of cancer, our incidence, our mortality rate higher than national. Look at liver cancer, almost 40% higher. Kidney, this is a national rank. So pretty bad. It's a lot of work we have to do to reduce the Louisiana cancer incidence and mortality. And then I just say talk about risk factors because Dr. Williams is expert on this, but I just say the risk factors, what we can do, modifiable risk factor, because tobacco use related to the lung cancer risk, oral cavity, larynx, esophageal, bladder, kidney, pancreatic cancer. So this is I look at just say the adult smoker, Louisiana 16.7, US 14, so we're higher. You see, this is a little bit higher, but you see, every 100 patients you hire, then you think about Louisiana 4.6 million population, then you see really high, right? Obesity is a problem. Obesity really increased risk of colorectal cancer, breast cancer, pancreatic cancer, kidney cancer. These cancer all on the list, right? Louisiana, you say that about 40% adult are obese. US, 33%. So we're high. We need to do something. HPV vaccination, this is really HPV infection-related cervical cancer, oropharyngeal cancer, anal cancer, say that 67% up to date, but the goal is 80%. We still have a lot of work to do. This is HCV is a virus infection, hepatocellular. This is the infection. Then we say 90 per 100 newly reported chronic cases. Hepatitis C virus infection. We, Louisiana, among the highest in the US. So then we say we really need to strengthen tobacco control policies. And I know we have done a lot, right? Expand access to effective cessation program, tobacco cessation program. And we need to support promotion, nutrition, physical activity, obesity prevention initiatives. Look at this increased risk, HCV screening and treatment expansion. Because now for HCV, there's some very effective treatment, right? Called the direct-acting antiviral medicines. This drug cure over 95% of patients. But maybe a lot of patients just in the community never diagnosed. So that this is something we should do, right? This is a reduce risk factors. Then I want to give you 2 examples, one colorectal cancer, one lung cancer. Say the early diagnosis. So this actually in if you Google Louisiana Tumor Registry, you can say this. See why all purple? You say what is purple? Purple means early stage, less than 50%. Almost all Louisiana parishes. And then this is stage distribution for all colorectal cancer data combined. Say that we have a 33% diagnosed regional. Regional means colorectal cancer already like either lymph nodes metastasis or the metastasis to surrounding organs. Distant, about 1/4 distant. This add together, you say that over 50% diagnosed later stage. I show this Louisiana data, 5-year survival. If diagnosed localized, means cancer still confined in the colon and rectum, 5-year survival rate 90%. But if distant, drop to 14%.
Yeah.
So this early detection extremely important. So this basically this is summarized, and also detect cancer early, colorectal cancer for better outcomes. And we know colonoscopy can just we do colonoscopy because they say maybe almost like 70% colorectal cancer develop from polyps. Development from polyps to cancer take 5 to 15 years. If everyone follow the guideline to have a screening, even probably not colonoscopy, maybe like a fit kit, then you identify polyps, removed, cancer can be prevented. So if we want to lower death rate we have to through early detection and treatment. This is something I know the cancer control program and Terry, taking aim at Louisiana, taking aim at cancer in Louisiana. That's this colorectal cancer is a focus, right? Just we need to increase colorectal cancer screening rate. This is colorectal cancer. We look at lung cancer, my goodness, all dark purple. Dark purple means early stage diagnosis less than 25%. So how we calculate, just a denominator all cases, numerator is early diagnosis, like a localized. Most parishes, early lung cancer diagnosis less than 5%. And you say the lung cancer, we say the distant over 50% patient lung cancer at time diagnosis, lung cancer already spread everywhere. And then that time your 5-year survival rate just less than 30%. But if diagnosed 90%, if diagnosed early stage localized, then 5-year survival rate 90%. Of course, I understand it's no for regular, the average risk is the people, no screening, right? They just say, but still we say the low dose CT screening for high risk group, at least, right? Then the public awareness, the warning sign, and act quickly. Then the regular primary care visit to assess risk factors. Because sometimes many people, I think, like old, especially senior, they find nodule. And if find nodule, you have to follow up with doctor, right? Cannot just stay. I have a friend just a nodule. Then COVID, 5 years after cancer, already metastasized. So this is say we need to just education, public awareness also important. So we just say colorectal cancer, increase colorectal cancer screening, because we say colonoscopy, we may not have resources. Everyone get a colonoscopy, you have to wait a long time. At least fit kids, right? And I know the Dr. Williams, the program just promote this because fit kids is at home test, no bowel preparation and no dietary restriction. So we need to just let more people to do this. And the lung cancer statewide low dose CT screening program, then just at least for high risk population. And then geographic and financial barriers, partner with local clinics and mobile health units to reduce barriers, and leverage telehealth. I think that's what Dr. Williams' team want to do to increase access, like virtual nurse or some, to clinical trials and special care, like a screening something. Environment patterns. Because we collect population-based data, yes, we can just generate cancer incidence rate at a small geographic area. Now we already published a report, just cancer incidence in Louisiana by census tract. Census tract very small, basically just several blocks. I say the standard the most time population census tract like 4,000 to 8,000 population. So we can just maybe use that, say the small area, because the parish level too big, right? Because some of the residents live close to the industrial site, and maybe they have higher risk. But if you at parish level, they're 50 miles away, when you combine all the together, then dilute, right, the findings. But we have some limitations. Why? Let me tell you, just you ask, small number can mislead. Because at census tract level, you say our overall cancer incidence rate, like per 100,000, we have about 400 cancer cases. Small, many just say the census tract make few thousand population. Then your case count very small. That's just say that we have to combine 10 years data together. So that's the problem. The small number can mislead, because sometimes in this area, one case increase, then your rate significantly higher than the Louisiana average. Small number. Multiple risk factors complicate interpretation, because Dr. William earlier this meeting mentioned this, because cancer, we say environmental, that's one factor, and also related to many factors like obesity, smoke cigarette, and family history, many other factors. Tumor registry, we don't have information about like other factors. We have obesity, but just at time cancer diagnosis. By time cancer diagnosis, maybe patient already reduced weight, not a usual body weight. So this is Dr. William mentioned, so we need to have a special research studies if we want to say whether there's a cancer increase related to environmental factors. And also long latency, not like COVID or the acute infectious disease you exposed today, maybe you got like flu, you got a few days after. Cancer latency, American Cancer Society publishes say that decades. So sometimes it just say that decades so long, there's so many factors already changed, right? So that we cannot just say use current exposure status and to assess the risk. So find association and also population estimate, because the legislative rules just say we publish data, just say population, this is a HIPAA actually, need to be more than 20,000. But if at census tract level, if we look at a single year, no census tract meet that criteria. So we have to combine 10 years of population data, 10 years of data together. But population data, normally the US Bureau of Census Bureau, they say 2010, 2020, every 10 years they count every single person, right? Then in between, they basically use American Community Survey, just a sample like a 2% population. So at state level, parish level, okay, but in small geographic area like census tract, population estimate probably not accurate. So that's another problem. So this is what I think. I'm not politician, so this may deviate from the protocol or something. I think act on known risk factors. If emission above EPA limits, just take action. Why wait for cancer data to show? That's it. Second, use existing exposure data like EPA's air quality system. There's a lot of available data, right? If you see in this area, the image above the level, then take action. We don't want to say if we go somewhere, they say that high pollution, we want to live there, right? So why wait? So act before cancer rates increase. Because the latency may take years, right? So that's what I think. Maybe deviate from the standard, but that's what I think. And then next is just LTR priorities and future direction. So we want to maintain excellence, sustain high quality, complete, timely data, because our data received the first place award from National Cancer Institute Cancer Surveillance SEER program for last 15 years or 16 years, just every year. So our data quality very good. We have to maintain high quality data, complete data, timely data, so we can support cancer control, cancer research, and also expand remote access to electronic medical record, health record, because we have to manually collect data. And many years ago, in 1990, we traveled to individual facility collect data. Since now our facility, they have electronic medical record, we want just remote access, because travel just takes time. But of course, we have to go through secure remote access. But right now, we're pushing through very difficult. Some of the healthcare facility, they don't want to say, oh, we still try to push it through. Otherwise, we're not able to collect complete timely data. Develop innovative approaches, automatic code data from electronic pathology reports. Even we actually, every year, we receive over 150,000 pathology reports. We manually code cancer site, histology, tumor grade, and but we work with the National Cancer Institute, develop use AI auto code, but we want accuracy rate over 98%. So now we can only auto code about 20% pathology report. Most we have to manually code. And extract data now captured in Louisiana Tumor Registry database by linking to medical records. This is also extremely important because data, we use a national standard. National standard, we only collect cancer like a cancer type, histology, something, and also first cause treatment. If we need to have a data, for example, we conduct study like lung cancer. We want to say that diabetes management to how that related to lung cancer outcome. We have no hemoglobin A1C data, so we actually request Ochsner UMC. We identify eligible patients, send to them. They append the hemoglobin A1C data. I hope we'll be able to do that for more facilities, not just a couple. And also for this, we want to develop some of the systems we can auto query the medical record for information we need. For example, clinical trial, because we can use pathology report, we can identify eligible patient, but sometimes they say they need all kind of lab, blood tests or some, we don't, standard data items do not include those. So we want to identify eligible patient, then we send medical record and auto extract. That would definitely help the cancer control program, help cancer research. And enhanced data visualization and repository access. We have data visualization too. I'll show you quickly, and support cancer control and clinical trial network. So just quickly, we have, if you Google Louisiana Tumor Registry, you go to our website, then there's a Louisiana map, you click, then we'll land to this page. We have 4 different kind of data visualization tools. This is interactive. For example, this one, I just use colon cancer. We have all the tabs you can select. If you want to look at the stage, you look at type cancer, survival, pediatric cancer, you can just choose different tab. This drop-down list, you can select cancer type. If you put your cursor, any of the parish will show you the number and also incidence rate. So you see, overall we decline. This purple, this Louisiana, but our incidence rate is still higher than the US. So that's our data visualization tool. This age group incidence rate. And this is a cancer in focus. This because I just show you lung cancer. So this is lung cancer, and this is CT scan, low dose CT scan site. Very few, right? I was thinking if a patient live here, they want to get the CT scan, they have to travel long distance. But this is American College for Radiology, just for the information about low CT scan site. But they say probably not complete because we find Oceana has one, but not here. And Dr. Williams' group already collect some information. So we work with IT to just update this. So they say probably 75, 80% active site. But even we say 75, 80% is still, even we add another 20%, still low, right? Still very few. And this one's colorectal cancer. I put the GI providers. See, some of the side, they start is the GI providers, but some of the area just no GI providers. There's access to care issue. Okay, then we have the dashboard. You can find like a different, you can choose like this obesity related and alcohol related or just exercise. So you just go to Tumor Registry website, and then you can find all this information.
Because I do have so many things that I want to ask, but Dr. Williams, we are excited to hear about what you have to say.
Sure, I'll try to go through those pretty quickly. Actually, I'm going to be talking from the sort of the perspective of, okay, now we have all this data. What are the issues that we can and should be addressing here? So I think, what we've seen and know to be the case that access to care is a major issue in our state. As you saw, we're fourth in the U.S. For incidence of cancer, many of which are preventable or can be detected early and cured. And the things that we see are compounded issues of rurality where people don't have access to a place where they can get to care, or they have to go miles away. They're the working poor. So if they have to take the whole day to go to a doctor's appointment, they don't get paid. They have to work through complex systems that they're not familiar with and do not even know how to access. There are transportation issues, and they may have multiple appointments. My husband passed away from colorectal cancer, and when he was going through his treatment, there were weeks where he had 4 different appointments at 4 different times on 4 different days. And so again, if you're trying to support your family, or somebody has to go with you and they don't work and you don't work, people are likely to forego that care, when they're faced with that. So we are an example being breast cancer. We're in the top 5 in the country for using mammography. And we saw from Dr. Wu's data that we're not above the national average for breast cancer, we're right at the national average for the incidence of breast cancer, but we're also 4th in the nation for deaths from breast cancer. So, this is where we start to see these things play out, where families can't access the care they need, even if they have access to early detection services. Then what? They either don't get they get a mammogram, the van comes around, they get a mammogram, but then they're told they have to go get a diagnostic mammogram or a biopsy or whatever. And so they never get a diagnosis till they show up in the emergency room with stage 4 cancer. Or they get diagnosed and then they're told they have to go 5 days a week for 4 to 6 weeks for radiation. If they do that, again, they don't work, they don't get paid, they got to find the transportation to do it, all of those sorts of things, so they never finish their radiation treatment. There is now a 3-week protocol for radiation, which is a little better, but still, if you don't work for 3 weeks and you don't get paid for 3 weeks, what does your family do with that? So, we see these things compounded in terms of why we're where we are. Same thing for colorectal cancer. It's easy to get a FIT test. That's something you can do in the primary care office. Simple test to get, but guess what? All roads lead to colonoscopy. So if you have a positive FIT test, you've got to get a colonoscopy. And you saw from Dr. Wu's map, all the colonoscopists are concentrated in metro areas. And so that all those things we talked about in terms of getting to it, accessing systems, all of that, really compounded here. That is, though, an opportunity for us to look at some things like some urban-rural partnerships, where we could get the small rural hospitals to set up some suites to do colonoscopy, but then how do we incentivize those urban practitioners to get there? That's an issue. That's something we can all work on together. Cervical cancer, no one should get cervical cancer, much less die from it. When I was a preteen, my aunt died of cervical cancer. That was my first introduction to cancer. My cousin came and lived with us because his mom was a single mom. So, but now we live in a time where no one needs to get it, much less die from it. But now we have more and more vaccine hesitancy. So we're starting to see the level of HPV vaccination level off or decline. We also have a very real impact from the Dobbs decision. This is a real policy issue here. OB-GYNs have left the state in droves. My own OB-GYN left. I don't have an OB-GYN right now. So the ones that have stayed are jam-packed with clients. And this exodus has really impacted, again, rural areas more than anything else. But it's more and more difficult for women to get in to see an OB-GYN. There's rarely a week that goes by that I don't get somebody contacting me wanting to know how they can get in to see a gynecologist. We do have the promise of self-collection now. Actually, this was my research work, so I'm very proud of this. This was something that we started right after Hurricane Katrina, that it can be done in private in primary care now. The woman can take the swab and go and collect it herself and get sent to the lab, and it's the exact same test. So we don't have to have a gyne anymore to do pap tests. All the women here cheer. You don't have to get in the stirrups. You can get a self-collection test in the office, just like you would do a urinalysis. You can do self-collection. However, it's again a case where all roads lead to colposcopy. If you have a positive self-collected test, you have to get to a colposcopist. And we've got a huge problem with access to that now. There is a potential. Advanced practice nurses can be trained to do colposcopy. And so this is an area, a policy area that we can all work on together to how do we get more nurses trained to fill in this gap here. Lung cancer, we saw the data on that. Right now, we have less than 15% of people who are eligible getting lung cancer screening. We know now that this is as highly effective as any other cancer screening, but we've got to get those numbers up. We saw the same problem with lung cancer that we see with colon cancer, and that everybody is concentrated in the urban areas. So how do we overcome those issues? That's more complicated because it's easier to set up a colonoscopy suite in a rural hospital than it is to get a CT scanner and a trained radiologist in that rural hospital. One of the places we have made some inroads, though, is there's a national quit line for smoking. And we have recently negotiated with them to make sure that anyone who's calling from Louisiana gets referred to my office, to our nurse navigators, to talk to them about getting in for lung cancer screening. So that's a big win for us. We'll hopefully be launching that after the first of the year, and are very excited that hopefully we'll see those numbers, the percent of eligible screened rise. Childhood cancer is worth talking with you guys, but all the screenable cancers have basically the same kind of overlapping access issues. I want to talk about childhood cancers real quick. We recently had some listening sessions with families that were dealing with childhood cancer. And some of the things that we heard were that, of course, access to care, again, particularly for families in rural areas. They're the only places for real access to care for childhood cancer are Manning Children's and Ochsner here in New Orleans. LSU Shreveport is associated with St. Jude, so they can access care there, and then St. Jude and Nashville. That's really limited care. And so for these families, they have all these issues piled up on top of issues, especially if they've got other kids dealing with mental health issues over there. So there's virtually no support in that area. And, you know, other children get neglected during this time, as we heard from them. And so they start to see a lot of acting out on a lot of issues that could be overcome with some counseling and family services for those other children. Traveling to these places and lodging. And again, even if you can get there and have a place to stay, but you can't work while you're there with your kid. What do you do with that? And then issues with home health and hospice, particularly as you got more away from the urban areas, not being prepared to deal with children. So lots and lots of issues there that are, you know, really, they can't help but tug at your heartstrings on that. And then Dr. Wu talked about environmental impacts, environmental issues, and there's so much we don't know. These are big question marks. Rare tumors, are those being caused by some kind of environmental impact? We're seeing more cancers in people below 40. Is it an environmental issue? Lung cancer among non-smokers. Microplastics, they're everywhere, as we're learning. And what effect is that having on us and having on our bodies? And PFAS, which are those forever chemicals that are everywhere now and we're being exposed to. These are unanswered questions. And the modifiable risk factors, obesity being a huge one. We're seeing more and more evidence now that obesity is a major, major risk factor for a number of cancers. And obesity leading to diabetes is the worst course, and lowers the body's immune system's ability to attack these mutating cells. And so we know, as Dr. Wu presented, 40% of our population is obese now. Smoking continues to be an issue, though our smoking rates have gone down. We're excited about that. Ultra-processed foods, more and more evidence that all these chemicals in ultra-processed foods may be leading to increases in cancer. Vaping is a question mark. The initial thought was that vaping was so much safer, it was harm reduction, and now there's more and more evidence that the things burning in the vaping device may be just as bad as the cigarette was. So that, you know, again, long latency period, so we may not know for another 10 years what that looks like. HPV and exposure to HPV and then alcohol are all potentially modifiable risk factors. I do want to take a minute to talk to you guys about the Cancer Center program, particularly the community outreach and engagement piece, because the policy arm of the Cancer Center is going to be under COE. And I know you guys talked with Dr. Millet. He is my boss in this. I'm one of the 8 associate directors, and my job is particularly around community outreach and engagement. I'll say that right here, we have 3 arms in community outreach and engagement. One is prevention, early detection, patient care and evaluation. One is research support, and one is community engagement. You'll see that this one is the most developed, and that's because this is the work I've been doing for the past 20 years. These are all funding sources that we have and programs that are in place. And then some things that we're developing out that you guys will be interested in is a One Health initiative. We're working with the Ag Center right now, the Ag Centers, both of them, to develop a plan to sort of up the game in terms of what the nutritionists are doing around the state. We have over 50 nutritionists that are mostly in rural areas that help train their communities and work with their communities on nutrition. And we're going to be working with them on nutrition as cancer prevention. So we're really super excited about that. Then the vet school, and everybody's like, the vet school. Well, the vet school does a tremendous amount of research on cancer because guess what? Our pets get cancer and our domestic animals all get cancer. And, we said 40% of people are obese, 60% of house cats are obese. So in terms of community outreach and a One Health approach, there's an opportunity there to work with vets on how we can think about health, not just in terms of our health, but in terms of our pets' health, especially in situations where people are more likely to take better care of their pet than they would of themselves. I'm one of those people. Another thing is dogs and cats rarely get lung cancer. They get it when their owner is a smoker. So many opportunities there. The other piece, though, that we're really excited about is the concept of the sentinel animal. We talked about these environmental exposures and the long latency with those and how they're hard to connect. Well, when working with the vet school, we may be able to take dogs and cats and other domestic animals that have a much shorter lifespan are more likely to develop cancer in a much shorter period of time. And we can monitor those animals. We can take their blood. We can see what they're exposed to and may be able to answer some of these questions more quickly using those sentinel animals than we would be able to with people. So we're super excited about that aspect. Just beginning, you don't see a lot of boxes and arrows here like you do here because this is new. The other, just to give you a quick the other two pieces that we're building out right now to give you a quick overview. This community outreach and engagement, the community engagement and education piece, we're developing a community health worker program and really being out in the communities, especially highly impacted communities, and engaging in ways that will help them understand and overcome some of their cancer risk. And then this research support is about a number of things, but we have a lot of research that's going on, and we want to help those scientists be able to communicate in a way that makes sense to people, because we tend to talk way up here, and we want them to communicate in a way that people can understand what the work is that they're doing and why it's important. And then we can get input from communities on how to do that research in a way where people will participate and benefit from it. We'll also, under that arm, we'll have some citizen science pieces where we can work directly with communities to collect data and do some public training, some grant writing and dissemination work. It kind of gives you a little bit of an overview of where we are.
The first thing that I kind of wanted to hit on, because we very much enjoy trying to improve the policy environment in Louisiana. And one of the things that I connected with right away is this lack of lung cancer screening. And what can we do around that? Where maybe are we not on par with other states? Or because I had one doctor who would give like an annual X-ray, but does that do anything?
The X-ray is not a terrific tool. That's why the annual CT scanning is recommended. It's a much better tool. This lung cancer is a tricky issue again because we can't just move a CT scanner into areas where there isn't one. However, there are mobile CT services. Now, this isn't unique to Louisiana. The entire country is dealing with people not accessing lung cancer screening for all of these similar reasons. Plus, it's an annual commitment, just like any other screening. So if we get them in once, does that mean we'll be able to get them in every year for that?
Is there trouble? Might ask, is there trouble with insurance companies paying for the screening, or
it's a covered prevention service right now? Now, what's going to happen with healthcare in the next few months, we'll have to wait and see, because some of the most at-risk people will likely lose their coverage. So, yeah. Yeah, and then, another issue with screening that and early detection that we have to be careful with in terms of policy is that insurance should cover the entire course of early detection up to a diagnosis. And so, for example, I'll use my own self. I have had polyps. And so now I'm under surveillance instead of screening. And so when I have to go every 5 years, and when I go every 5 years, I get a big copay because I'm no longer considered screening when I'm now, because I have polyps, in one of the high risk groups. So there are certainly gaps in our insurance coverage, and there are cases where, and I just had a talk with our health department about Medicaid and making sure when they add copays to Medicaid, they don't add copays for screening services until there's a diagnosis or an all clear. So don't do a mammogram and then say, oh, you've got a $20 copay for a diagnostic mammogram or a $50 copay for a biopsy. That's where we're going to lose people.
Yeah, I actually had a bill for that a long time ago, maybe 2019 or 2018, that the follow-up mammography after, a possible after a possible detection of mammography would be covered at the same category of coverage, so that it would be free of copays. Yeah.
Yeah.
But all the other cancers, there's probably nothing there. I think it was just for breast cancer.
Yeah.
A few other things is I look at some of those policy opportunities, and I saw lung screening, but we're set up to where we have they're supposed to cover it, but some kind of way only 15 or whatever percentage were actually getting that test. So what could we do to increase that? But it sounded like there really wasn't necessarily anything per se that we could do.
Well, I think, it's a fairly new screening modality compared to the others. So I think getting the word out is important. And I think making these connections with the highest risk people, like we just did with the quit line, making sure those people get referred in, and, working within systems to make sure that they're asking about their smoking history, because sometimes they may just ask, are you a smoker? And they may say no, but they smoked for 20 years. And so they may be in a high risk group and may need to get referred. So how do we connect the dots, basically?
But who normally refer patient? If for someone is just no primary care physician,
right?
And who they refer themselves?
No, they would have to get referred from some kind of primary care. So that's where our nurse navigators can come in. If they don't have a primary care doctor, we have a centralized nurse navigator system that will work with people to get them in for primary care so they can get that referral they need.
Yeah, because there's a lot of people that don't. I know people that don't have a primary care doctor. And 1 minute you have a primary care doctor and then they move to another state.
Yes.
Yeah. So also the advanced practice nurses for doing colposcopy, is there something that would need to be done there, or what was the status of that?
Well, there's a couple of things that need to happen. It's covered under their practice plans, but they have to have a collaborating physician. So we have to be able to link them up with a collaborating physician. Now, the really cool things, some of the cool things we can do right now, there's mobile colposcopy that can actually be attached to a smartphone. They can transmit an image to a physician who's away from them. And so in real time, they can say, hey, I'm looking at this. I'm not sure what it is. Can you give me an idea? And they can talk back and forth right there. So wow. There's technology is our friend, and we need to be able to use them more. What we need to be able to do is get these nurses in. There's a didactic portion. There's a national group that does the didactic portion of the training. And then again, we need to hook them up with a physician to get sort of the hands-on training. But again, with the mobile colposcope and the smartphone, they can do that remotely. So it's, again, putting all those pieces together and hooking them up, but also getting the cost for that for the nurses, it's kind of multiplied because we have to get them in for the course. The course has to be paid for. And then while they're doing the course, they're doing their hands-on training, they're away from their job. So, how do we make all of that happen? So.
Yeah. I see Terry Burkhoff has her hand raised.
Look, these are my colleagues I've worked with for so long, and just excellent presentations. Dr. Wu, as long as I've worked with you, I think I've learned one or two new things. And Donna, I always learn new things from you. I do have a couple of questions. Number one, Dr. John Lyons had raised the red flag on liver cancer. And I saw in this new data that Dr. Wu presented that, he just kind of confirmed what he was saying, that we have a real problem with liver cancer. So I wondered if there's been any other discussion about what could be done about that. And then the second question has to do with colorectal cancer and early onset. I am volunteering for the Louisiana Colorectal Roundtable. And one of the things we want to look at is early onset. And I know Dr. Jordan Corliss has done some research with the tumor registry data and identifying, I can't remember now, 11, 13 parishes in southeastern Louisiana where we have, a higher incident rate.
Yeah.
And the French-speaking white male population, that's a higher than the national average. Is there any new data that has come out on this, or is it the data we still have from that research project that Dr. Corliss did?
We're working on paper called Early Onset Colorectal Cancer. I think the paper already submitted for publication. We do, we look at it. But I think early onset colorectal cancer, even we say overall colorectal cancer incidence rate decline over time, but early onset actually increase, right? Like 2 years ago, we say they increase, but the case count is still very small. I think it's because we talk about under age 50, just I recall just a few, less than 300-400 cases or something, just very small. But we still monitor, look at that. I don't know what we can do because now the colorectal cancer screening lower age, right, to 45. But actually between 40 to 45, some people may develop a cancer and never get screened because unless they have family histories. That's a very good question. We are, if you're interested in that, we can provide you update the report. The early onset colorectal cancer,
And as you know, Terry, it could be an Acadiana, it could be a founder's effect. But also, I think we're seeing this increase in younger people all across the country. So it could be microplastics, it could be ultra-processed food, it could be obesity, it could be a combination of all of that.
Right.
So it's really, just like environmental, it's really, going to be difficult to tease out exactly what that is.
But thank you both for the excellent presentation, really.
I do want to mention one thing that I didn't have in my presentation that's hopefully going to come up. Working with some folks on this next legislative session that y'all might be interested in. We're working with a gentleman out of California, and it's called Ryan's Law, if y'all want to look it up. He had a son who died of pancreatic cancer. And when his son was in the hospital dying, the hospital would not prescribe and would not let them bring in THC to control his pain and symptoms, and wanted to just put him on morphine. Now, having been through that with my husband, when he got diagnosed, he was having so much trouble with nausea and vomiting, and this was when THC was not not decriminalized. And so after I went on a rant about why can I get a semi-automatic weapon, but I can't get medicinal marijuana, I had friends come out of the woodwork with the names of their guy and a couple of suckers and all of these kinds of things. And it was miraculous at how it controlled his symptoms. But then when he was in hospice, they just put him on morphine. So we lost that time with him. And that's the issue, is that THC can be effective in controlling pain symptoms and not having to lose so much time, and the person is just not responsive because they're on morphine. And so this is a place where you guys could jump in on this, and I would be happy to hook you up with the gentleman from California who's trying to get this passed in every state.
So I have a question though, because we have medical marijuana now. And so wouldn't somebody just be able to, tell me why, because we have
he's a better expert at this than I am. The problem is that the hospitals get federal funds and they're afraid they're going to come under fire if they use it in the hospital, that they could lose their federal funds. So what Ryan's law essentially is taking that that liability away from the hospital. You have to bring it in yourself, and it can be stored and dispensed in the hospital. But I don't know all the legalities. I'm not a lawyer, but it admonishes the hospital from legal responsibility for the use of that product.
Okay, because we have been approached about that, and we haven't been able to figure out why. So, so it's not when you're at home, it's when you're in a facility.
Yes.
I see.
And so we're not talking huge numbers of patients, but we're talking about a place where it can make a big difference. Because he said what they eventually ended up doing with his son is they pulled him out of that hospital, found a hospital that would let them bring it in, and they were able to have some last days with his son that they otherwise would not have been able to have.
I see. Yeah, great point. Okay. So glad to know that, because like I said, this has come up. One question I wanted to know is, so do 45 other states have tumor registries? Is that the way I was understanding that?
Yes,
okay.
Correct. Because this is before, before 1990, just only few states had cancer registries. But then the Cancer Act amendment, I think this Congress just really they expand to all the 50 states. Yeah.
Okay, good. All right. And, what do you have in place for, I don't think we voted there was like fence line monitoring to see what sorts of chemicals inhalants were getting through to neighborhoods, et cetera. But we didn't pass that, did we?
They passed the law that now communities can't do their own monitoring and publish those data. So it's horrible. Yes.
And, so what are other states? Is it different in other states? Why would you stop from being able to? Okay.
Yeah, because they don't. It's pushed by the chemical industry. They don't want. There's low cost monitors called Purple Air, and they don't want the community members doing their own monitoring and then publishing how high the rates of whatever chemicals are in those communities. So that it's strictly to keep the data from getting out there. I haven't looked at what other states are doing, but I'm sure that, it could have been a case where we were the first state to do it, but I'm sure others have followed if we were. But
yeah, right. And then let's see, I'm just looking through, and if anybody has a question, this is your moment, because I am why do you think we have, it's like all the digestive sort of cancers we seem to have really bad rates of. And I wondered if it's more south of the I-10 or if it is uniform throughout. Because, I know we have really bad obesity rates, and I just wondered about drinking, because drinking is so much more prevalent south of I-10, than it is in the north
Yeah.
part of the state. And I just wondered if there was a relationship.
I'm
Because
gonna let
we
Dr. Wu
don't
answer.
collect data drinking. We only collect because the standard data items. We collect we actually not all the population-based cancer registries collect the tobacco information. We collect because we 10 specialized cancer registry. But regarding drinking, I don't know whether that information in medical record or
Well,
not.
it could be an interesting thing to look at in terms of we can certainly get the alcohol sales by geographics. And it would be interesting to look at the alcohol related cancers versus overlaid with the alcohol sales.
Yeah.
That would be interesting, Julie.
I always wonder, because we all run around thinking, it's not going to hurt anything, but I wonder about that. All right. Well, I don't see any other questions. So, I just really want to thank you guys for giving us your time, after 5 o'clock too, because I see that we have drifted beyond that hour. So thank you, Dr. Williams. I've really gotten to know you over the years and really appreciate what you do. And Dr. Wu, I'm so happy to have met you. So thanks for joining us and the important work you're doing. Mission critical stuff. So we greatly appreciate it.
Happy to come anytime and talk about anything. And if I don't know the answer, I'll go back and see what I can find out.
Wow. I appreciate you both so much. You're doing great work. And, to everyone out there listening, thank you for being part of the conversation. And we appreciate your engagement and hope you have a great rest of your day or night, as it may be at the moment. If you're interested in these types of policy talks, check us out on Ellevate Louisiana's website, where you can learn more about our events, our policy committees, advocacy efforts, and how to join. That website is ellevatela.org, ELLEVATELA.org. If you enjoyed this episode, don't forget to subscribe, leave a review, and share it with someone who needs to hear it.